Center, and I'd like to welcome you to the Preparing for Managed Care for Family Peer Support Service Providers webinar. I'm also joined by my colleague Ann Cuppinger, along with our state partners. Just some housekeeping before we get started. After today's presentation, the slides and recording will be posted to our website, mctech.org. We always like to remind everyone that information and timelines presented are current as of today. And while we will discuss some of the specifics related to the implementation of this service, you will need to refer to the provider and billing manuals for official guidance. We do plan on having a brief question and answer period if time allows, so please feel free to submit your questions via the chat box at any point during the presentation. The chat box is located on the right-hand side of your screen. If you don't see the chat box, if you look towards the bottom of your screen, you should see a dialog bubble. If you click on that, the chat box should appear. So as I mentioned, we're joined by a number of our state partners who will walk us through our agenda today. We will begin by providing a brief overview of family peer support services and then the credentialing and certification process. We will then talk about how families may access this service, some of the fundamentals for billing, Medicaid managed care, and then review utilization management and medical necessity for this service. As the children's system is undergoing a number of transitions, here is the most current timeline that details some of the key elements. For our purposes today, we're going to be focusing on the July 1st implementation of family peer support as a children and family treatment support service. This is the fourth of the 6 new services that will be available on its implementation date. A few reminders around the implementation of family peer support. Some children have been receiving family peer support as part of the 6 waivers that ended on March 31st. In order to ensure continuity of care, family peer support has been authorized as an HCBS service until it is authorized as a CFTSS service. While services are authorized as an HCBS service, they can only be provided to HCBS enrolled children. On July 1st of this year, family peer support services will be implemented as a CFTS service and will be available to all Medicaid enrolled children who meet the appropriate medical necessity criteria. And that being said, the remainder of this presentation will address family peer support services when implemented on July 1st. Again, for more official guidance, please refer to the manual, and when the slides are posted, you will be able to access that here. And with that, I'm now going to pass it off to our state partners.
Good afternoon, everybody. My name is Maria Morris-Groves, and I have the privilege of being the team lead on the Adolescent Women and Children's Issues at the State Office of Alcoholism and Substance Abuse Services. Myself and Meredith Labatt from the Office of Mental Health are going to walk you through the next section. So we're going to start by talking a little bit about what Family Peer Support Services is and what it's supposed to do. Next slide, please. So family peer support services are an array of formal and informal activities that support and provide services to families caring for or raising a child who's experiencing social, emotional, medical, developmental, substance use, or behavioral challenges. They're structured to be strength-based. They're to show the relationship between a family peer advocate and the parent-child caregiver to benefit the child. So a couple of things to remember about the information on this slide is, one, it is about restoring the functioning as it relates to the child. So helping the parent or family caregiver better work with that child to help them further develop. And we also define family here very broadly. So family can be the primary caregiving unit, and it is inclusive of a wide diversity of primary caregivers. So family is a birth family, a foster family, adoptive family, a self-created unit of people that reside together with a significant attachment. So just be mindful of that as we go through the conversation today. You'll also hear us talk about the 2 types of folks that can deliver this, the family peer advocate or the certified peer recovery advocate with a family parenthetic. So if we go to the next slide, we'll talk a little bit more about the service itself. So Family Peer Support Service has 4 components to it: engagement and bridging and transition support. So I like to think of this one as when the family is looking to either begin services for the first time and really wants some support and encouragement from someone who's got similar lived experience with whatever the issue is they're dealing with. And also a time of transition and support. So when a child is coming back from perhaps a residential placement, or they're looking for the appropriate type of placement, as well as navigating from one service to another, and even being able to help identify what's the appropriate service for that child. That's where I think that bridging and transition support, as well as helping to engage, is really important, and we can do some really good work with family peers. Self-advocacy, self-efficiency, and empowerment. This is vitally important because this is where the family peer is able to help empower that other family member or caregiver to really act on the best interest of their child and their family. Perhaps helping to navigate that system of care that we're working so hard to develop, or even helping to identify services that are appropriate for them to access. And what that experience with a specific service has been, a specific provider, or knowing how to ask the question, or most importantly, not being afraid to ask the question. Parent skill development. That's a really important one also, because it's a time where another parent helps coach a parent into how to deal with a specific type of disability, maybe how to begin to understand recovery for that youth with a substance use disorder, or even understand the concept of family recovery, that just because a child gets help doesn't mean that the family instantly gets better, but the whole family has to recover. Or if a child has got a recent diagnosis that's significant, how do we navigate that? How do I cope with that? How do I parent a child with some of those needs that we're now learning about? And then lastly, community connections and natural supports. Really helping the parents to identify the folks in their community that can be supportive, be it the faith community, the school community, maybe it's a lodge or family that they just haven't even thought about talking to. And when they do, that organization, that family, that community connection really wants to be helpful and supportive. So it's another way of helping the parents identify how we can wrap some services, or how we, not even services, but how we wrap connection around them and really support them as they move forward with whatever they're dealing with. I think that's something that all of us do as natural supports, but maybe for a parent that's facing a child with a new diagnosis or a new placement in residential care, helping them figure those connections out and where that support is, or not being afraid to say, my child has now been placed residentially, or, my child has behavioral needs that need to be addressed. And being accepting of that, and then helping the community also become accepting. So if we go to the next slide. So why would we offer family peer support services? I think the family members out there would probably say, why not offer family peer support services? We offer them because of the lived experience the credentialed family peer advocates and the certified peer recovery advocates with the family specialty have, because they know how to engage other parents, they can help problem solve, and they can help alleviate barriers to care and really help with that initial engagement into services. We're talking about promoting a family-driven practice, so not only being child-centered, but being family-centered, so that we look at what the needs are of the whole family unit. In the addiction service system, we talk about really making sure that the family understands the recovery process, not just for their child, but for their family. I would imagine, in the systems of care, that would be very similar, is that the whole family needs to learn how to move forward with what's happening in the family. We want the practice to be inclusive of parents and families and caregivers so that they're active partners in the planning and delivery of the services for the child and the family. And I think a peer can help, as we talked about with those components, really help bring the family caregiver to the table and make that connection be worthwhile. It increases social support by connecting to parents to other parents who can relate to what they're going through. Again, that lived experience is vital to this whole process. And the Family Peer Support Service works directly with parents to enhance their capacity to parent a child with challenges. And I think with that becomes lots of opportunities for the families that we're all working with in the community. So with every challenge, there's an opportunity, and with every opportunity, there may be challenges to getting there. But I think that peer really is the bridge to help making all of that happen well. And the Family Peer Support Services can promote continuality across the different services a child is seeing: school, mental health, primary care. They can be a bridge that kind of helps the parent or the caregiver navigate these different systems, understand from a parent's perspective what questions should be asked, and how further to navigate. So if we go to the next slide, we're going to switch gears a little bit and talk about staff qualifications. So family peer support can be delivered by individuals with lived experience who have completed the necessary requirements as a credentialed family peer advocate, which you can contact Families Together for more details on the training requirements, or as a certified peer recovery advocate with a family parenthetic. And if you can contact the New York Certification Board for additional information. So for the SERPA F, that means that someone has or is working toward being a certified peer recovery advocate, and then they meet the additional qualifications and do the additional work toward becoming a family certified peer recovery family advocate. Please note the FPAs may be best suited to serve children with mental health needs diagnosis, where SERPA Fs may be best suited to reach those with a substance use need or diagnosis. And please also note that, as we go down the path of what all of this looks like, there may be some of our sister service agencies or systems that also look to develop their own peer credentials. But right now we're talking about these two that really happen in the world of behavioral health. So if we go to the next slide. Lived experience. So the parent, biological, foster, or adoptive, or the primary caregiver of a child or youth who has had significant social, emotional, developmental, medical, substance use, and or behavioral needs or disabilities which manifest itself prior to age 21. So you have to have had that lived experience with your child prior to the age of 21. Oftentimes when I talk about this, I get a question that, well, my child's no longer 21. Can I still be a FPA, or can I still be a SERPA F? And I say to them, so when did you first start to experience the lived experience? And if the child was under the age of 21, then you certainly can begin to talk that through that way. So then we go to primary caregiver as a person who's primarily responsible for the day-to-day care of the child. And the broadness of this definition gives us the opportunity to be inclusive of non-traditional family arrangements. So we're really looking to be very broad in how we define the parent caregiver with the lived experience, with the challenges happening before the child is age 21. So if we go to the next slide. Criteria for the professional FPA credential is here. So the individual has to be over 18 years of age. They need to have a high school diploma or a high school equivalently preferred, or a state education commencement credential may be waived if the individual has needed competencies. They need to complete the parent empowerment program training, and they have to have 3 letters of reference, one from the FPA supervisor, and 1,000 hours of work or volunteer experience providing family peer support services. Adhere to a code of ethics, and have 20 hours of continuing education a year. And if we go to the next slide, the SERPA F parenthetic, again, 18 years of age, lived experience, a high school diploma or the GED and equivalency, 46 hours of content-specific training covering the topics that are listed, 20 hours of training on family peer support, 500 hours of work-related or volunteer experience. That 500 hours can count as part of your 1,000 hours needed for the SERPA, as well as 25 hours of supervision in a peer role with continuing education credits, including the ethics there. And if we go to the next slide, we talk about who can supervise the SERPAs. Individuals who have a minimum of 4 years experience providing FPSS services and at least 1 year as a credentialed FPA or SERPA F with access to clinical consultation as needed, or a qualified mental health staff person with training in FPSS or the role of FPA and SERPA F. Efforts made at the FPSS service gains maturity in New York State is to transition supervision to experienced credentialed FPAs and SERPAs. The other person who can supervise is a competent behavioral health professional who meets the qualifications of either a qualified mental health person, staff person, or a certified alcohol and substance abuse counselor working within an OASIS certified program. The individual providing consultation, guidance, and mentoring and ongoing training need not be employed by the same agency. So an agency could contract for the supervision as appropriate. And I believe if we go to the next slide, we're going to talk a little bit briefly about provider qualifications. Agencies must be designated through the New York State Children's Provider Designation and Review Team. This requires agencies to have appropriate license, certification, and approval. And some agencies may also need to provide be certified or licensed by their oversight agency, and we'll review that at a little bit more detail as we go. And I'm going to turn it over to Meredith, who's going to talk about the pathways to care.
Thank you, Maria. Hi, folks. My name is Meredith Ray Labatt, and I'm with the New York State Office of Mental Health. I'm in our Division of Children and Families, and I work very closely with Maria on the various services associated with the Children's Medicaid redesign. I'm going to be talking to you today about pathways to care, which is basically how children can access family peer support services. Next slide. Great. So obviously, children and youth can access family peer support services in a variety of different ways. Family peer support services are available to children if they meet certain medical criteria. It's called medical necessity. So if they are thought to have a behavioral health need that would really benefit from a family peer support service for them and their family to help them and support them in the challenges that they're encountering in their home, in their community, in their environment, a referral could be made to a family peer support organization. Now, those individuals who can make a referral are people such as the parents or caregivers themselves, a pediatrician, a care manager, someone from the school, or the young person themselves, obviously. Individuals can self-consent for services once they hit a certain age. So there's a variety of ways in which someone can access the services just by the nature of a referral, which basically call someone up and say, I have a child who might benefit from your services. Now, because these are rehabilitative services, similar to what might be in the physical health world, such as speech therapy, occupational therapy, or physical therapy, children can also be referred by a licensed practitioner. So if, for example, your doctor feels as though you hurt your knee and it really won't heal until you get 3 times a week for 6 weeks physical therapy, they will make what's called a recommendation, also called a prescription for the service, so that they have medically cleared you and medically determined that you need physical therapy. It's the same concept for children who have a behavioral health need who would benefit from family peer support. A licensed practitioner of the healing arts, which is a physical health doctor, a pediatrician, or a primary care physician, or it could be a therapist or a clinician, so someone who's a social worker, can make a recommendation in writing that the child meets the medical necessity for the service, and and that will enable them to access the service. In order to get family peer support services, the child needs to have a documented diagnosis. Again, in the cases of accessing a family peer advocate or a certified recovery peer advocate with a family parenthetic, CERPA-F, you would need a mental health or a substance use diagnosis. And if the child doesn't yet have a diagnosis, though, certainly a referral can be made to a therapist or someone else who can diagnose them to see if they would meet medical necessity for the service. So if a referral, so just to be, I think the next slide, if you go to the next slide. Great. So just to clarify, a referral can be made by anybody, but it basically means that the family peer support organization would need to make the medical necessity determination themselves or help facilitate someone making a medical necessity determination that the child would qualify for the services. But if a recommendation is made for the service directly from a licensed practitioner, that means that somebody else external to the family peer support organization has made the medical necessity determination, and therefore the provider doesn't need to. So those are the two differences between a referral and a recommendation as to how a child can access the services. So anybody can refer, but licensed practitioners of the healing arts can recommend and access the service just like a doctor can for physical therapy. Okay, so here are a number of various types of licensed practitioner of the healing arts that actually can make a recommendation for the service. Again, they would basically, based on their either knowing and treating the child on an ongoing basis, or they're conducting an assessment of the child, they would be able to determine whether that child meets the need for this service, and they would submit in writing to the provider a recommendation that demonstrates that the child meets medical necessity and that the family peer support provider can begin providing services with that family. That process is outlined here. So the state has drafted a example form. It's not a required form, but it's certainly one that would meet the needs of what a licensed practitioner would need to complete. And it's in the link provided below. So it's a sample form, and that could be provided to somebody's pediatrician. It could be provided to somebody's therapist, and that individual could complete the form and submit it back to the family peer organization to show that and demonstrate that the child meets medical necessity in order to access the service. So sometimes there's different ways in which that can occur. A referral could be made to a family peer organization or a family peer support provider. If that provider is getting a referral for a child who doesn't come with a diagnosis or a recommendation, and they happen to have in that organization either a clinic or a other licensed practitioner, OLP, that person can do an assessment for the child and discern if they meet medical necessity in order to access the service. However, if the family peer support organization doesn't have within their larger agency either a clinic or other type of licensed practitioner, like under OLP, they might have to facilitate that child getting a recommendation through either an existing service provider, if they have a pediatrician or they're engaged with a therapist, or might have to make a connection to get that child to a clinic or an OLP. In order to get referrals for service, it's likely going to be important for family peer organizations to start forging collaborative working relationships with providers in their catchment areas. Providers such as pediatricians, it might be a school therapist, or it might be other clinics in your area. And I would encourage family peer support organizations who don't have a connection in-house in your own agency to a clinic or OLP to start explaining to other practitioners in your field and in your catchment areas the value of family peer support and what you can offer children and their families who are struggling to really function well and navigate the varying child-serving systems that they might be engaged in, to demonstrate the benefit that a family peer advocate and or CERPA-F, same thing, could provide to a child and family in their community. So those relationships are critical for pathways to care and for receiving referrals or for receiving recommendations from licensed practitioners, and those will help facilitate referrals for children to serve for family peer organizations. So next slide, please. Okay. So I've mentioned it a number of times. So what is this medical necessity? How does a child qualify for these services? As I mentioned, the child or youth has to have a behavioral health diagnosis that demonstrates symptoms consistent or corresponding with the DSM. So basically, the child must have a mental health or a substance use diagnosis. That's what behavioral health means. As Maria mentioned earlier, there is a kind of a placeholder for children who might display skill loss or underdevelopment as a result of their physical health diagnosis. This is kind of a placeholder if New York State were to explore an opportunity to develop a credential for a family peer who would serve those with physical health diagnosis. That is not available yet, but certainly, hopefully in the future. So for the purposes of today, certainly a mental health or substance use diagnosis is required. They have to be able to attest and demonstrate how the child is likely to benefit and respond to the service to either present the onset or worsening of their symptoms. And of course, obviously, with any service, you need consent and engagement, so the child and family is available, receptive to, and demonstrates the need for improvement in the following areas. And things that children would benefit from are things such as strengthening the family unit, building skills within the family for the benefit of the child. Again, the services, family peer support services, are all for the benefit of the child because they're the identified patient, so to speak, and they're the ones who you're providing the service for. Even though that service might in large part be provided to or with the parents and caregivers, it's all for the benefit of the individual child. And that's very important to keep in mind, particularly as you're thinking about who may benefit from the service or how you market or describe what it is that you would be doing as a family peer support organization and a service provider. Again, promoting empowerment within the family and strengthening overall approaches to the child's environment. Any service provision obviously is not intended to be lifelong. For rehabilitation, you're rehabilitating and you're supporting the child and the family, so the idea is to empower and to teach and to support the child and family's ability to continue the work that you've started with them on an ongoing basis. Obviously, services are recommended by a licensed practitioner of the healing arts, which is what we just talked about. So either the recommendation is coming with the child from a licensed practitioner, or the service provider is responsible for helping to secure a recommendation if they just receive a referral for the child, and there needs to be a demonstration of need based on the medical necessity criteria by a licensed practitioner. Next slide. So once the child comes to you and medical necessity has been established, the service provider is responsible for developing a treatment plan. So the treatment plan, obviously, is a plan for how you're going to provide services to the child based on the needs that have been identified through the assessment or through the medical necessity determination. And so each family peer support service needs to have a treatment plan. And so the treatment plan will include the services, how often the services will be delivered, by who the services will be delivered by, what are the goals that the services are intended to achieve, how you will achieve those goals, and what are the actual activities and interventions you will be providing to address those objectives and goals. The services obviously are provided in accordance with the treatment plan and documented in the use record. So those are progress notes. So every interaction and every contact with the child should have a reflective progress note. This demonstrates that you have provided a service and that you can bill for it and claim for it. Obviously, treatment planning is an active and ongoing process that involves discussion and conversation with the child and family. All services are provided in a family-driven and youth-guided way. And as such, ongoing review of progress is required. So in a regular regular intervals, a treatment plan review should occur to make sure that the goals are being met, the objectives are being met. Are there any changes that need to be made to the interventions, into the scope, the nature, the frequency of the services that are being provided? The state of New York has not provided a template for what a treatment plan must look like. We've just provided, the basic elements of what should be available on a treatment plan, and we've talked about that a lot. But what's important is also, in addition to the person providing the service and developing the treatment plan with the child and family, they should sign the plan. The child and the family should sign the plan. The child, as appropriate, sometimes if they're too small, they can't sign their name. But there should be a note in the record as to why the child may or may not have signed the plan. Then the supervisor must also sign off on the treatment plan, the supervisor of the family peer support individual. The treatment plan is not the same as a plan of care. Some children, not all children, because you can get family peer support services without needing to be engaged or meeting the criteria to be engaged in a health home. Some children may be in a health home receiving care management services. When that is the case, the health home is responsible for developing what's called a plan of care. That's a care coordination tool that lists all the various types of services that a child and family are engaged in, whereas a treatment plan is very specific to the service that's being provided by the service provider. So the service provider has the treatment plan outlined with all the things that we just talked about, and the plan of care is something separate and apart that's maintained by the health home care manager. That does not go into the great detail of the individual service that the treatment plan does. So they're two separate things. And there's a lovely little handy-dandy two-page guidance document on that at the link provided herein. Next slide. Okay. So we're going to briefly go over some case examples, and I'm going to start with this one. Veronica shared with her teacher's daughter that despite all of the services that Mia, I probably should have thought of that before I said it, Mia was receiving, it really wasn't working for her family. So you can get all the services in the world. Sometimes it doesn't work. So things were going better in school, but still she was unable to manage Mia's behavior at home, even with all the good suggestions made by her providers. She also shared that she recently lost her job and was probably going to lose her housing and felt overwhelmed and lonely. So the teacher made a referral to the family peer support service provider. The family peer support advocate met with Veronica, and together they contacted Mia's clinician, who agreed that family peer support would be helpful and then made a recommendation because the therapist knew the challenges and struggles that Veronica was undergoing and really felt as though they were impacting her ability to support Mia and help her implement her goals that were being established on the clinician's treatment plan in the clinic. So really felt that family peer support would help Veronica, but also help Mia as well. So the family peer support advocate met with Veronica and listened to her concerns, reassured her that they would support her to work through some of these issues. And together they decided that they would focus on supporting her to talk with Mia's providers, help her to implement their suggestions at home, and connect her with a family peer support group, and help her to apply for services, to find community resources to help with housing and food. As we know from Maslow's hierarchy of needs, sometimes the most basic needs are the most challenging to get help with. And so I think that certainly helping with community resources for housing and food will help her achieve all of the other goals that the family peer advocate and Veronica worked out together on their treatment plan. Next slide. So I'm going to pass this over to my colleague, Maria Morris-Groves, at the Office of Alcoholism and Substance Abuse Services.
Okay, so Claudia and Manny's son, Aiden, age 17, was recently hospitalized due to an overdose. He was discharged to a clinic in the community for ongoing mental health and substance abuse services. He lives with his parents. He's not been participating regularly, and his providers learned that his relationship with his parents was strained. So the clinic knew from past conversations that the family was feeling judged and afraid for their son. So the clinician made a referral or a recommendation for family peer support services, hoping that the SERPA-F would be able to make a connection based on their shared experience and engage a family in the conversation about how best to meet everybody's needs. So the SERPA-F could potentially be working for the clinic, or they could be working for an agency that provides FPSS services. And the F met with the family, and they learned that they were at a loss for how to support their son. And they are also concerned about boundary settings and what was healthy for everyone. The SERPA-F helped the family reconnect with the clinic, maybe got them engaged in family services at the clinic, helped them learn how to set some boundaries related to their son's diagnosis, and really worked on getting the family to understand recovery. So they connected Aiden's siblings with recreational activities in the community that might give them extra support, but also nurtured that family through that recovery process. So that's kind of the role of a SERPA-F. Next slide. And I think we're turning it back over.
Yes. Great. So we had, as hopefully many of you are aware, because I'm sure all of you were on the various earlier presentations and webinars that we had done about family and peer support over the last couple of years when these were imminent to be implemented. We've gotten a lot of questions from all of you. Thank you so much. And so we thought it might be helpful just to highlight for you some of the common questions that have come up in the previous webinars that are quite consistent in each of them, so that if you had them, you could get them answered right up front. So can a child who meets all appropriate medical necessity criteria receive home and community-based services and family peer support services? So the answer to that is yes. Certainly a child can receive CFTSS services, and if they meet the HCBS eligibility and level of care for home and community-based services, they can also receive those services. Some of you may be familiar that there's a service, be aware that there's a service called Family and Caregiver and Family Supports and Services, which in some ways can be considered similar, or family peers can often do some of the things that are outlined in that service. A child can receive both services as long as the services are doing different things for that child. So there shouldn't really be an overlap in what each of the service providers are doing. But if a child and family is identified as needing additional services and support beyond what the family peer support person is doing and what's on that treatment plan, then that service can also be provided to address other needs that the child and family may have. Again, does a child need to be part of a health home to receive family peer support services? The answer to this is no. None of the services under the Child and Family Treatment Support Services, that's CFTSS, require that the child be in health home to access them. You might be aware that the level of eligibility for health home is fairly high. You need 2 chronic conditions or a singular condition of something such as serious emotional disturbance. You don't need serious emotional disturbance or to access this service. You can have just a behavioral health diagnosis, again that's mental health or substance use, and some identified functional deficits as determined by a licensed practitioner, which is in accordance with the medical necessity that we just went over, to access the service. You don't need to be in a health home. Finally, is family peer only available to children who are eligible to receive Medicaid? The answer to that is no, only because family peer support is actually funded by the state through the Office of Mental Health. So it might be that your child doesn't have Medicaid, but they too can access family peer support services. So if you're interested in finding out more about that, you can contact your local Department of Mental Health. But in order to receive this family peer support service, which is a Medicaid reimbursable service, yes, children have to be in Medicaid. But we didn't want to discourage you from finding out about the other family peer support resources that might be available to children in your community who may not have Medicaid. And if you're interested, again, contact your local county Department of Mental Health. And finally, how can a family peer provider know what other services the child is receiving? So again, this is really part of the first meeting process, where you're talking with the child and family and you're starting to gather the information necessary for your developing a treatment plan. So if you're to ask the questions about the other services they're engaged in, if you do find out that they're part of a health home program, you can certainly contact the health home care manager and speak with them as well, and make sure that you've made that connection. But having the conversation with the family about what they're engaged with and the services they're receiving is what you would be doing upon your first few appointments with the family as you're developing, gathering information and developing a treatment plan. Next slide. Okay. So really briefly, can a family peer support be provided to a family whose child is in a hospital or a residential program? Now, the challenge here is that a service can be provided, but unfortunately it cannot be reimbursed through Medicaid. If the child is on Medicaid while they're in the hospital or a residential program, such as an RTF, Medicaid is being billed for that service. If they're in a setting where Medicaid is not being billed, then that's potentially a different story. But you can't bill Medicaid for a time when a child is in a hospital RTF because these settings are already billing Medicaid for that time. Now, again, as I mentioned, there are some local family state-funded programs. We call them 1650 funded programs. Well, all the information's there. That could help offset costs if a service is provided. So if an agency is also a 1650 funded program by the state, which are state aid dollars, those services can be provided while the child is in the hospital or in the RTF. And we are OMH is in the process of drafting guidance to also help inform providers about the use of the CFTSS services in community residences as well. If a family peer program without an LPHA on staff receives a recommendation from an external provider, what's the recommender's role intended to be post-recommendation? So this is going to vary in practice by who is the licensed practitioner making the recommendation. So, for example, if it's a therapist serving the child, they may actually play an active role to support the treatment plan and the coordination of care. So if a therapist in a clinic or in a program, such as an OLP, has provided a recommendation and clearly outlined for the family peer support agency the things that they have identified in their assessment are needed to be addressed, they might want to play a role and help coordinate their care and help support the work of the treatment plan. But regardless, either way, the family peer support provider should work to assure communication and collaboration with the relevant treatment providers. So depending on the role, it might be that the OLP is within the organization where family peer support is available. The other licensed practitioner might also serve as the person who develops the treatment plan and supervises the family peer worker. There might be a myriad of relationships and structures in which the, treatment planning is facilitated and organized within the agency, depending on their resources and the array of services that they have available to them. So it will vary depending on who's making the recommendation. Next slide. I'm going to turn this over to our colleagues at MCTAC.
Terrific. Hi, everyone. This is Ann Cuppinger from the Managed Care Technical Assistance Center, and I'm going to briefly go over some aspects of billing Medicaid managed care for these family peer support services. And because we're going to go through this fairly quickly, I really would encourage you to feel free to chat questions to the host that we'll collect, and if we don't have time to answer them on the phone today, we'll be gathering them up and producing a Q&A document that will be posted along with the slides. So a few billing fundamentals. If a child is in Medicaid managed care, providers will be billing the managed care plan for family peer support services. Those plans are required to pay government rates, in other words, the fee-for-service rates for at least 24 months from the date the service is initiated, in other words, July 1st. Or longer as New York State mandates. If a child is not in a Medicaid managed care plan, and there are some situations when that will occur, the provider will bill fee for service. We're going to talk a little bit about contracting, and there are situations in which you might not have a full contract with the plan, but you can work out a single case agreement in order to ensure that children can receive services as needed. So in order to bill a plan, there are a few things that have to be in place. And I think most of you are fairly far along in this process. You have to be a designated provider of family peer support. You have to be enrolled as a Medicaid provider agency, credentialed with the plan, and contracted with the plan. There is a very helpful matrix on our website, on the CTAC website, which gives you lots of information about the plans and various contact people with those plans, and you can click on your jurisdiction and get more information. So there is a billing manual, and it has a lot of really helpful information. There is a section on family peer support, but I would strongly encourage everyone, including people who aren't individually responsible for billing, but who may be just providing the service, to really take a look at that billing manual in its entirety to get a little bit of a better understanding about how billing works. Billing for family peer support services will take place, will be done in 15-minute units. You will be able to bill for individual and group services, and you can provide the service on-site at your agency or off-site. Although, I would remind everyone that with these FPSS services, the goal is to make these services as home and community-based as possible. Submitting claims can be done electronically or via paper submissions, and the plans are required to have options for how you submit those claims. I think if you've been to any of our trainings, you've heard us talk about claims testing. It's very important that you do claims testing prior to July 1st, well in advance of July 1st, hopefully, so that you can work out any challenges that you have with your system communicating with each of the plans systems. You will not be able to do claims testing unless you are contracted and credentialed. And obviously that requires you to be designated and that service is listed in your contract with the plan. We really recommend that even if you have experience billing managed care for any service, that you test out these new services as well. And I would take this minute to really stress to everyone that if you encounter any difficulties in this process of contracting, credentialing, and claims testing, that you get in touch with the state immediately, because oftentimes there's some information that can be shared that will help clear up any difficulties that you might be having. The good news about coming live in July rather than January is that a lot of those things have been worked out, but please don't wait too long before you get in touch. So the managed care plans are all held to specific requirements by the state. One of those requirements has to do with them having an adequate network. So they're looking to contract with you. If you haven't heard from a plan, reach out to them. And again, your goal is to be in network with the plans that serve children in your area. A plan can deny a claim from an out-of-network provider. There is an exception to that for these services if the provider is delivering a service to an enrollee prior to the July 1 implementation date. So again, if you have any issues with this, this will be a kind of situation in which you'll want to be quickly in touch with the state. So a few lessons learned around contracting for managed care that you want to really read these contracts, and you want to make sure that you're being paid government rates. You want to, line up that contract language with the language that's in the billing manual and also in the model contract that the state has issued, the rules around contracting between plans and providers. For authorizations, plans and providers have to follow the units as outlined in the billing manual, and both the plan and the provider have to do that correctly so that claims don't deny. Just a reminder that an authorization letter is not a guarantee that claims will be paid. So again, this is, you've heard us talk a little bit about how you monitor claims as they work their way through the billing process, just to be sure that you're getting paid for the services that you provide and to quickly address any barriers that might come up. Again, ensure that the services you are contracted to provide are accurately listed in the contract, and make sure that you are contracted with the proper line of business in the plan. So these plans offer commercial programs, Medicare programs, and Medicaid programs. So you're going to want to make sure that you're contracted for the right service line. And plan notifications. So you're going to want to let the plans know who you're currently serving, that or when the family is enrolled in a particular plan, you want to give that plan a list of those families just as a heads up so that they know you're going to be submitting bills on behalf of those families. It'll help smooth that process over. We're also encouraging you to, again, review those contracts carefully, and you'll see in that second indented bullet there some standard language that's recommended to be included in your contract that really just says if there's any disagreement between this contract and the state-issued model contract, that the model contract guidelines will prevail. So that just provides you with a little added protection. Again, look at the amendments, any amendments to the contract as well. Some of you will have contracts and you're just amending them to add these services, but you'll want to really take a look at those. And I think, again, we talk a little bit here about single case agreements. And, you know, you wouldn't want to live for long with single case agreements or have a lot of single case agreements. They shouldn't be a substitute for developing a full contract, but it is an option if you're finding that you have a single child or a child, if you're not yet up and running with a full contract, you can do those single case agreements to sort of bridge that gap. Again, contact the state if you have any questions. So some additional information now. We're going to change gears a little bit and talk about and medical necessity. being utilization management. And utilization management is really just a set of procedures that are used between providers and plans to evaluate whether the service is clinically necessary and appropriate, whether it's working, and whether it's going to be authorized on an ongoing basis. So there are different types of authorization reviews, and will take place at these different points. For family peer support, there is no prior authorization. So we are asking you to let plans know which families you're serving, but you can go ahead and start serving those families without prior authorization. Concurrent review takes place a little bit later when you and the plan are talking about whether or not there is ongoing necessity to continue the service. So for concurrent review, the provider will submit for concurrent authorization to the plan, and you have up to 3 visits before authorization can be required for additional services. So each plan has their own policies regarding concurrent review, but they cannot require it before 3 visits. Some may not require it at that point, and that's something you're going to want to learn about from each of the plans that you have a relationship with. The plan will review the authorization request and any supporting documentation that you submit to evaluate it for medical necessity. And there is a template here that you can use for concurrent review, and it's available. When you see these slides, you'll have a link to that template. A treatment plan will be required, as Meredith mentioned, but it's not used for the purpose of obtaining authorization. And again, Meredith talked a little bit about medical necessity. It's really, and this is the state definition, it's really meant to determine whether the services are necessary to prevent, diagnose, manage, or treat a condition and that interferes with the person's well-being and daily activities. So there are specific medical necessity criteria to initially obtain family peer support. And then there are medical necessity criteria for them to continue to receive family support. These are the criteria that are necessary for them to continue. And in some, they say that the child still meets the admission criteria, that they're making progress, but they haven't accomplished all their goals, that the family is engaged and involved, that psychoeducation is helping the family, and that progress is being made, or that you anticipate progress being made. And that the child doesn't require actually a different service that's more appropriate, and that the child is at risk for losing skills if it doesn't continue, and that the family and caregivers are involved in the planning. So those are things you're going to need to demonstrate to the plan when they require you to seek continuing authorization. So there are also criteria for discharge. I think in the interest of time, I'll let you take a look at those on your own. This is also important. There is no that will take place for 180 days beginning on July 1st for this service. So what we're talking about, what we just talked about, really kicks in, after 180 days from July 1st. This table and the one on the next page allow you to look at which services can be provided at the same time. So Meredith talked a little bit about making sure that you have different goals. If there are two services that are similar, that's important, but there are also some hard and fast rules about services that you can or cannot get at the same time. So you can take a look at those. They're probably impossible to read on your screen, but when you enlarge it, hopefully you'll be able to see those. And I just want to quickly just point to these last few slides so that we can have just a couple minutes for questions. These will come to you. They give you links to all of our tools, including a billing tool, which will help you fill out those bills, links to the manuals that we've talked about in this presentation, links to Families Together and to the State Certification Board for credentialing, and also the email addresses that you may need if you have further questions or encounter any difficulties. So with that, I'm going to turn it back over to Maria and Meredith, who will have time to answer a couple of your questions.
Meredith, if you don't mind, I think I'll take a stab at one right away. Is that okay?
That sounds great.
All right, so we have a question that says, if a family does not have a child with a substance abuse issue, would a SERPA F be able to work with the parent? So the SERPA family is really about restoring the functioning to the family as it relates to the child. I'm going to read into this question a little bit and say that maybe there's a parent with a substance use disorder or potential. That's where a certified peer recovery advocate or certified recovery peer advocate that's working in one of our clinics could work with that family member. But the SERPA F has been designed to really be related to the child with a substance use disorder and helping the family cope with that situation. I hope that was helpful.
Thanks, Maria. That's a great clarification. And I had read into that question that way, so I think that's wonderful insight. One of the questions was, can these services be offered now to children who were not previously in waiver programs? I'm assuming that means that they are previously were in the waiver programs and are continuing to be in the waiver programs. So again, starting in July 1st of 2019, Family Peer Support becomes a Child and Family Treatment Support Service, CFTSS. And at that point in time, starting July and after, Family Peer Support Services will begin to be available to all Medicaid-enrolled children who meet medical necessity criteria for Family Peer Support Services. So yes, currently, as we speak, because it's still May, a child who is not receiving HCBS services and not enrolled in the children's waiver cannot yet receive Family Peer Support Services. But starting in July, which is why we're prepping you with this webinar, this service will be more broadly available to all children who have Medicaid and meet medical necessity criteria.
And we have another question that says, do FPAs or SERPA Fs do a treatment plan? Yes, you do. And if you think back to the example that I spoke about, the SERPA F or the FPA, if they were dealing with a co-occurring issue and they happen to be seen on the mental health side, would write a treatment plan that would talk about mom and dad being confused and concerned about stigma and how they might work to make some community connections. There was one about restoring the family's sense of well-being, and by connecting family members with other community activities and helping them deal with the transition and hopefully learning to parent the child with those needs. That's how your treatment plan would spell out, and it would be directly related to the things that you're doing with a measurable goal and objective attached to it.
So with that, we've reached the 1 hour mark, and I apologize that we've left a few questions unanswered, but I want everyone to rest assured that those have been shared with our state partners, and they'll be responding to those in the Q&A document. I'd like to thank everyone for attending today. Please continue to send us your questions, and I hope everyone has a nice rest of the day. Thank you.